Chapter 19 will cover diabetic emergencies and altered mental status. Pathophysiology into that mental status. The reticular activating system, RAS, is the neurological circuit that's responsible for that normal level of consciousness that regulates the functions of staying awake, paying attention, sleeping habits, making sure a person's alert and oriented. There are some things that need to be in place for the rest to function properly. You have to have appropriate amounts of oxygen to perfuse the brain, produce energy. So production of energy also ties in with that glucose. Now that happy balance of glucose and oxygen and water is all that's needed to create that energy production, which maintains that normal level of consciousness. Causes of the altered mental status would be deficiencies in the oxygen, the glucose, the water, drying up and unsaturating that brain tissue. So hypoxia, low blood sugar, dehydration, any kind of mix to disbalancing the oxygen, glucose, and water. Also trauma, infection, toxins, brain damage, strokes, a variety of things that will be covered throughout this presentation. To assess the patient with an altered mental status, the patient with an altered mental status can be very dangerous. It doesn't mean that that is normally a dangerous person. It's just if their mental status is altered, they're not in their right state of mind. So, prime example, had a friend at the fire department went to a diabetic call. Person had low blood sugar, didn't have normal mental status, became very combative. Just because that blood sugar was low, they just weren't themselves. They didn't know what they were doing, and they cannot recollect why they became combative. It's just misfiring of the brain. Of that primary assessment, always monitor those A, B's, and C's. Any kind of life-threatening emergency you see first, correct that. Give supplemental oxygen, and also knowing what the baseline mental status is for that patient. Are they truly altered, or is that just your subjective opinion of what is altered? When conducting that secondary exam, it's very important to note that even the slightest change in a mental status can indicate a serious medical or traumatic issue. Examine those body systems first. Whatever you think could possibly be causing this change in mental status, examine that first. So a known diabetic with an altered mental status, checking those blood sugars. Also, be interviewing the family, anybody you can, to start doing your CSI detective work, trying to figure out what has caused this change of mental status. You go and ask the history and figure out their medications or medical history. Those two can lead you into forming that differential diagnosis of what has caused this issue. Also, look for indicators at the scene, such as maybe possibly drugs, noted, medical alert bracelets, any kind of environmental thing you could think of as well. Children, a lot of times they're not going to be able to answer for themselves, or they may just be completely too shy to answer. So asking those parents or somebody around, is this patient acting different than normal? Since they will be the ones that know what normal actually is. Diabetes, one of the biggest causes of that change in altered mental status. So having that oxygen, glucose, and water, diabetes throws that glucose off tilt of that maintaining that normal level of consciousness. So glucose is a form of sugar as the body's basic source of energy. The body needs that happy balance of glucose to be able to create the energy, maintain that reticular activating system. But glucose molecules are very large, and without insulin, that insulin's kind of what holds the glucose hand to go into the cell. So without insulin, the glucose will not go and be metabolized. The pancreas is the organ responsible for producing insulin. The pancreas is located in your epigastric area, right at the xiphoid process, near just to the side of the liver. So the insulin enters the bloodstream, binds to the blood sugar, binding that glucose, so that the cells will take on the glucose so it can be metabolized. Otherwise, it will just continue to recirculate. There are two different types of diabetes. First type is type 1. That's where the pancreas is not properly functioning. The insulin is not being produced normally, and there's just not enough insulin production. So the type 1 diabetic requires insulin shots. The type 2 diabetic, the body's cells aren't using the insulin properly, so they're going to have to take possibly some medications, or they can maintain and regulate through just a good proper diet. But there is a little bit of dysfunction in what's going on, so it's just not the average person that diets and feels better. There is still a body's issue at the cellular level. So type 1 requires insulin. Type 2 can be controlled through diet and may take an anti-diabetic medication. Some very common of those anti-diabetic medications, big ones you're going to see, metformin. A lot of the diabetics who just have to take a pill take metformin, but here's a long list of some other common ones you may see. So in the diabetic emergency, hypoglycemia is that low blood sugar. Causes of that, the patient could have taken too much insulin, or their loved one knew that they're a diabetic and they weren't acting right, so they gave them another insulin shot, making it drop. The diabetic doesn't control their diet well, overexertion or over-exercising. The diabetic begins vomiting, getting all the nutrients, everything out of their system, just depleting themselves. Or the person who has had a high fever, shivering, just overexerting the body once again with the shivering, just anything that will speed up the energy production process. Hypoglycemia is a very fast onset, whereas hyperglycemia, we'll talk about later, is a very slow onset. So the blood sugar can drop very fast. This patient may mimic just having a drunken stupor. They could be pale, sweaty, have a high heart rate, fast breathing, have seizures, many different types of signs and symptoms. A low blood sugar can also mimic a stroke. The low blood sugar essentially starves the brain cells, not enough energy production occurring to maintain that normal mental status, so they can be a little bit altered or completely unconscious, and it can end up causing permanent brain damage. Hyperglycemia, meaning high blood sugar, this is just could be caused by the body's decrease in natural insulin production, not taking their insulin or their medications, poor diet, multiple things. Also caused by stress and increased dietary intake. So the patient who just has a really poor diet can end up developing high blood sugar. Also, a good note is if your patient is on a steroid medication, say they have a respiratory infection, those steroids will cause the blood sugar to spike. So just because that patient has no history, if they're on a steroid, their blood sugar may just be high. This is delayed over a long period of time, days, weeks, go into making that blood sugar go up. They'll be very thirsty, hungry, have increased urination, and can be nauseous, vomiting, have slurred speech, just general lethargy. Patient will also be profoundly dehydrated from the body peeing so much and from them being thirsty, because the body's trying to flush all the stuff out every way that it can, so they'll become dehydrated. If it gets really bad, they'll develop diabetic ketoacidosis, DKA. DKA will generally have a profound altered mental status. They'll have the signs and symptoms of shock, low blood pressure, high heart rates. They'll be breathing fast because their body will become acidic, DKA acidosis. So if the body becomes acidic, it will breathe fast, trying to lower the pH scale of the body, or balance it out rather, and they'll be breathing fast. When you breathe fast, it'll blow off the acidity of the body. They can also have nausea, vomiting, or an acetone or fruity smell on their breath. Acetone smells kind of like fingernail polish remover. In that secondary assessment, get an idea of the history of that present episode. How long did it start? What all's been going on? Any signs and symptoms? Was there any injuries or anything else that could go into this altered mental status, such as trauma? Do they have a fever, infection, seizures? Checking blood sugar. Really just painting a full picture to get a full understanding of what's going on with the patient. And always use your mnemonics of sample, OPQRST. Get as much information as you can while you're on scene. If you can't get it from the patient, find somebody who can give it to you, or look for indicators such as medicines in the fridge, identification bracelets, list of medications, pill bottles in the kitchen, bedrooms, wherever. But just don't delay transporting that patient while you're trying to stay on scene, do detective work. Always take a blood glucose reading of an altered mental status patient. And blood sugar problems can cause that. Even if it's not patient has no history of diabetes, always take a blood sugar reading. If it's less than 60, those are generally the symptomatic patients that get treated. Now, I have seen patients before who are much less than 60 and you would not notice. Walking, talking, looking fine, just feel weak, and may have a blood sugar of 30. And I've seen patients become symptomatic right at 60, even 70 ranges. The blood sugar that's over 140, hyperglycemia. If it's over 300 for prolonged amount of time, those are the patients that are going to become in DKA state, diabetic ketoacidosis. They'll have profound dehydration and can lead into much more serious symptoms such as stroke, seizures, multiple things. Those glucometers may also give you a reading of high or low. That doesn't mean high like it's turning on just saying hello to you. That means it's too high for it to completely measure out what all was in there. It just measures it, sees, yep, that's a whole bunch, and puts high. Most glucometers, that means that it's over 500. Depending on the manufacturer, that may mean if it says high that it's over 500, 600, 650. Those are about the averages. And most generally all of them say low if it's under 15. Sometimes to fix that hypoglycemic patient having the low blood sugar, sometimes what you gotta do is just help them get something to eat. This doesn't mean give them a Snickers and a Mountain Dew, possibly what kind of situation got them into their diabetic state, but give them some good natural stuff. So give them orange juice, apple juice, some natural sugars, natural carbs, or a big favorite of EMS is performing the peanut butter protocol. We'll make the patient a peanut butter sandwich, give them a glass of milk, enough to where they can get peaked up, get to moving around their own, fix themselves a meal, and get their blood sugar back up. But don't ever give anybody food or a liquid if they can't maintain their own airway, such as giving them oral glucose. But if they're alert enough to look at you, talk, swallow, give them something to eat, or just give them oral glucose. After you do give them oral glucose, just reassess. It does take a little while for it to take effect. So if you get oral glucose, not perking them up, not getting your desired result, contact medical command and possibly get another dose. And if all else fails, call for ALS backup. So some differences between hypoglycemia and hyperglycemia. Hyperglycemia, slower onset, where hypoglycemia is a very sudden onset. Their blood sugar can drop very fast. High blood sugar, they've also generally got the warm, red, dry skin, while the low blood sugar patients generally cold, clammy, sticky feeling skin, because their body is in shock. If there's not energy production going on in the body, you'll see it in the skin, so it'll become sticky and cold. With hyperglycemia, You may note that acetone smell on their breath. It may smell like they just drank fingernail polish remover, or they may have a fruity smell on their breath. That's just from the ketones being developed in the body because of the poor blood sugar being very, very high. We'll talk about some more common causes of that altered mental status. Good mnemonic to remember: AEIOU TIPS. Now there are multiple versions of this, but the most basic is of AEIOU: A, alcohol; E, electrolytes or environmental. If they're dehydrated, are they really hot? Are they really cold? Insulin, is it a blood sugar issue? O, oxygen or overdose. Are they hypoxic? Have they just completely overdosed on drugs, opiates, narcotics, different things? Uremia, thinking about if the patient has any kind of issues, say with renal failure, their kidneys and liver failing, big major chronic issues with that. With TIPS, trauma for T, infections, is that patient really fevered, possibly septic? Psychosis, do they have a history of psychiatric episodes, or are they having a stroke, or have they had a seizure? Sepsis is basically an overview of problems dealing with infection. Sepsis can occur from a normal small infection, a wound that goes untreated and becomes a systemic problem, meaning that they had a small wound or had a open surgical site that they didn't care for and became wide and spread infection throughout the body. If it's severe enough, there'll be microbes and everything released due to the infection that can end up making the body go into shock, reducing cardiac output, therein reducing the mental status of the patient. With that, you're going to find a few things with the septic patient. They may have an altered mental status, increased heart rate, increased respiratory rate. Generally, every time there's a fever in a patient, the heart rate goes up. The body's battling something, so the heart's going to go up. Increased respiratory rate, there's infection. So with infection, they're going to breathe fast, trying to get the acidity all out of the body. Low blood pressure from being in shock, a high temperature, they will have a fever, and possibly a body odor. Whenever they're releasing, the toxins are released from that infection, their body will put off a weird smell. It's very hard to describe, or as DKA, it's acetone smell, but the septic patient will just have a weird smell. If you've ever smelled anything that's rotten from getting moldy and stuff like that, the body's kind of doing the same thing, so they're just going to smell really dirty. Could smell like soured urine. So it's a very nasty smell. Not really pungent, but just slightly noticeable. Seizures, basically a seizure is the brain's electrical activity has just went nuts, that there's something that has disrupted the brain, whether an injury, infection, something, and the electrical system's just going nuts and just misfires in every which direction. It can be a sign of an underlying defect or an injury or some disease, but it's just not a general disease in itself. There's something else that goes on that causes the person to have seizures. There's two types of seizures. A partial, basically only affects one part of the body or one side. They may or may not lose consciousness. And then there's generalized. Basically, the entire brain's misfiring. The generalized is a more common type of seizure you think of, where they're on the ground doing the kicking chicken. As an example for a partial seizure, I used to help coach Special Olympics in Upshur County, and there was a athlete on the softball team there that just every so often would just kind of twitch, but never lost consciousness. Could be looking at you talking the whole time, but they were having partial seizures. Just every few minutes they had a twitch, and that was classified as a seizure. The tonic-clonic seizure also was formerly known as the grand mal seizure. You'll hear patients talking about grand mal seizures. It's grand mal, GRANDMAL, not grandma and grandpa, whereas some older populations will tell you that if, say, a wife tells you her husband, who's an elder gentleman, had a seizure, she will tell you he had a grandpa seizure. Just because he's old enough to be a grandpa, he had a seizure, they'll call it a grandpa seizure. But a tonic-clonic seizure is the most common type you'll see, with the tonic phase, the body being rigid and stiff, and the clonic phase is being the body jerking. In these, the patient is definitely unresponsive. If they do this maneuver and then they come back and tell you they had a seizure, they were faking it. These patients go completely unresponsive. After that, they'll have a postictal phase, meaning after the convulsions are stopped, it may take them a little while to regain consciousness. For one, sometimes in the seizures, they'll become apneic, not breathing, so they can be hypoxic. All the electrical signals are trying to realign, refire as they should. So they're going to have that postictal phase, being confused, really weak. I've seen spouses that have been married for 40 years not recognize their spouse after having a seizure, that it may take 15-20 minutes for everything to get back to their normal state of consciousness. Some seizures are preceded by what's called an aura, where they may feel something, see something, smell something. A really common one I've heard some patients say is they suddenly smelled oranges, or they saw a bright light and had a seizure. A lot of people do have chronic seizures, so a lot of times, and honestly, a lot of seizure calls end up being refusals just because they may be in Walmart by themselves, have a seizure, and it happens to them frequently, and people who don't know call. So, but if it's unknown history of seizures, that's a very significant emergency. Like I said, some people will sense that they know they're about to have a seizure. They've had it before. When they see the bright flash or smell a certain smell, they'll know they're going to have a seizure, and they'll just lay themselves on the floor and get ready to have a seizure. So different causes of seizures: hypoxia, the brain just irritated from lack of oxygen; a stroke, once again, brain just being irritated from either a lack of blood supply or pressure on the brain. Same thing can occur in that traumatic brain injury. Toxins, patients who've overdosed on medications. Once again, just the brain's mad. It doesn't like what's going on, what's being fed into it. Just a wide change in the body can cause seizures. I've seen patients who've overdosed on narcotics, heroin, or not heroin, but cocaine, have had seizures just because of those overdoses. Low blood sugar, especially in little kids, that blood sugar goes low. Once again, the brain, not happy on what's going on, will seize. And fever. Most commonly, 98% of pediatric seizures are caused by fevers. Brain tumors, congenital brain defects, infection, metabolic issues, and idiopathic, meaning just that new onset of some kind of medical emergency that they're not sure what it is causing that seizure. So sometimes that seizure will be the indicator or the symptom of the underlying ailment. For instance, I knew a guy who had a seizure, was in his 30s, never had really any history, had a seizure, went to the hospital. Since he'd never had a seizure, found out he had a large brain tumor. Epilepsy, at bright flashing lights, so that's why it's very important when you show up to the call of a seizure that you turn off your bright flashing lights of your ambulance. Childhood diseases such as measles, mumps, eclampsia. Eclampsia is the pregnant female whose blood pressure is really high, can make them in a pre-eclamptic state, and their blood pressure is too high they're fearful of, so if they become fully eclamptic, is the hypertensive pregnant woman who's having a seizure. And heat stroke, environmental things like that. So when you're assessing that patient, you need to ask the questions of, tailoring those questions. What were they doing before the seizure started? What did they react like? How long did that seizure last? Was it only one? Or the time it took you to respond, or did they have multiple seizures? And how they reacted after the seizure. Just kind of trying to paint that picture of really what happened to get a full understanding of what kind of seizure you had. Because remember, a lot of times you ask these people what happened to the patient, they can only tell you subjectively what they see or saw. They're not medical experts, so you have to ask them in layman terms what happened, so you can put your CSI detective hat on and medically think of what happened. If you witness a seizure, the biggest thing you have to worry about is that patient, while they're seizing, hurting themselves from flopping around on the floor. So have them on the floor. Say if they're in a chair, get them someplace flat, get them in an open area. If they've got restrictive clothing on them, say they're in a shirt and a tie, loosen everything up and remove objects away from them that could cause harm. So if they're in the middle of the floor, move the chairs, tables, things away that they could convulse, strike their limbs on, and hurt themselves. Don't ever try to hold them down, do anything, because severe stress is another one that can cause seizures. So if you got a patient laying on the ground seizing and you're sitting on them, slapping them, telling them to quit seizing, that immense amount of stress is not going to make them stop seizing. There's nothing you can do to stop seizing outside of giving some very heavy medications. Once the seizing is stopped, check those ABCs, protect the airway, give them some supplemental oxygen, or ventilate them if you have to. Most of the time they come back to, they need some oxygen, just some good TLC, and some comfort and calmness to get back to their normal state. If they have experienced 2 or more seizures in a row without regaining consciousness, or if a single seizure lasts more than 10 minutes, that's considered status epilepticus. That means that's a very bad seizure. Even most patients who have seizures don't have seizures for that long. If they're that long, they are in need of some major interventions. So with that, you definitely need to call a paramedic. Stroke is essentially death or injury of the brain tissue from oxygen deprivation. So 2 basic types of a stroke: an occlusive, which is just a blockage of that artery so blood flow doesn't get to it, or a rupture, a hemorrhagic stroke. Just a blood vessel is ruptured. So same thing, if there's a blockage on the opposite side of that blockage, no blood supply is getting there. If the blood vessel has ruptured, there's a blowout in the vessel, no blood's going to continue to circulate to part of the brain. So with that disruption of blood supply, it's generally going to be to one side of the brain or the other. So it's going to cause signs and symptoms generally to one side of the body or the other. So they may have weakness or paralysis to one side of the body, slurred speech, a headache, generalized confusion. So severe confusion, generalized confusion, maybe dizzy, not Disney. Be numb, have some weakness, paralysis. Most of the time that's just to one side of the body or the other. So the right arm may suddenly start tingling and it may just kind of feel weird. They could have incontinence, which means they've lost control of their bowels, impaired vision, blurring, high blood pressure. Usually high blood pressure is a precursor to a stroke. Some more things: difficulty breathing or snoring, difficulty in swallowing. They can have nausea and vomiting, experience seizures, unequal pupils, or the most uncommon one is complete unconsciousness. They will be hard to communicate with, as they're going to generally have an altered mental status. So they may be able to look at you, they may be able to understand what you're hearing, but they may have developed aphasia, meaning that they have a hard time being able to speak and communicate. A TIA is basically the same signs and symptoms of a stroke. It's just something that will resolve on its own, generally within 24 hours with no intervention. They will look exactly the same. You need to treat it exactly the same until otherwise determined by the hospital. So assessment of a stroke. You're looking for speech difficulties. the facial droop to one side of the body or the other, or one side of the face, they'll just have a facial droop. So it'll look like they just completely lost all the muscle tone in the side of their face, and it looks like their face is just sagging. You'll perform the Cincinnati pre-hospital stroke scale. Basically, first step of this is ask the patient to close their eyes, put their arms straight out in front of them, and hold them for 10 seconds. When their arms are sticking straight out with their eyes closed, palms up, they're going to see if they can hold their arms in the air for 10 seconds. A positive finding of this is if that patient's arm, whether right or left side, will droop and fall down without them even knowing it. And tell them to close their eyes because, for one, it can increase anxiety if they can see their arms and see one arm drooping, because if their eyes are closed, they won't know that their arm is falling. So if you can see the droop or rotating of the wrist or the palm, that's a positive finding for the stroke scale. Also, asking them to smile and speak. When they smile, see if you see any facial droop, and when they speak, or if you just start up that conversation with them, you may hear the slurring in their speech. Or ask them to say something as simple as, "You can't teach an old dog new tricks," and see how much their speech slurs. Biggest part is going to be keeping everybody calm and relaxed. Pre-hospital wise, nothing you can do for a stroke. So you get them in, make them comfortable, keep an eye on the airway, making sure that they're not going to vomit, then aspirate, or quit breathing. So otherwise, keep an eye on their ABCs, give them oxygen, making sure it's staying above 94%, and just keep an eye on them. Otherwise, checking for those life-threatening conditions. You're going to transport them to a stroke facility, someplace they can actually manage a stroke. Otherwise, it's going to delay the care if they get to a hospital. Very few hospitals can truly treat and fix a stroke. It's very, very time sensitive, so if you get them to a hospital, they can intervene. Sometimes they can reverse all the effects of it. Otherwise, if you take them to a local hospital, that's just going to delay the care as they go on and say, yes, they got a stroke. Now that hospital has to take time and send them to another hospital. So the goal is get them to the closest appropriate facility. That questions to ask is, when was the last known normal? Even if that means they found them in bed in the morning and the last time they saw them normal was 8 o'clock at night before, the hospitals ask the timeline they have to go on, because at 8:01 they could have had that onset of a stroke. So asking the exact time onset and the symptoms, anything else environmentally that could be going on with it. For dizziness and syncope, that can also indicate a life-threatening problem. That could be also the precursor or the indicator of something underlying going on. Dizziness is just the common term. Is vertigo is sometimes confused with dizziness. Vertigo is a sensation of all the surroundings just spinning out of control. I'm sure some of you who've ever engaged in a fraternity party or some kind of party on campus have experienced vertigo in your life. So you hear the stories of those drunks who get in their bed and they hold on to the bed because the room's spinning. That is vertigo. Lightheadedness is just that sensation you get before you're about to pass out. And passing out, actual term for that is syncope. That's that brief loss of consciousness without that has a spontaneous recovery, meaning you just pass out and you wake yourself back up. There's no interventions to wake you back up. Generally, it's very short. I'm sure probably everybody has had a syncopal episode. Everybody's probably passed out sometime in their life. So some causes of that can be cardiovascular related, whether it's a slow heart rate, fast rate, causing that decrease in cardiac output, not enough blood getting up to the brain, making you go to sleepy timeout mode. A vagal syncope is result of stimulation of the vagus nerve. As we talked about, if a patient has a high heart rate, you can make them do vagal maneuvers to get the heart rate low. So one such maneuver is bearing down, acting like they're going to have a bowel movement. So just imagine if that can lower the heart rate. Say grandpa in the toilet hasn't had much fiber in his diet lately, is really struggling to have a bowel movement. is pushing down really hard and can make themselves pass out. Those kind of calls are not fairly frequent, but do happen quite often of pass down the toilet, didn't know why, and they were just straining to pass one out. Hypovolemia, whether they've lost blood or vomit or some kind of fluids from whatever substance, they've just lost the volume in their blood, their body can produce hypovolemia. So not enough blood and fluid getting up to the brain, as well as metabolic and structural issues, like such things as lack of electrolytes, things like that. Also, structural wise, inner ear problems can cause that vertigo, syncope. If anybody's ever had any ear issues, you've probably experienced this where you can't hardly walk a straight line just because your inner ear. Environmental toxicological issues, alcohol and drugs. You get drunk, you can get dizzy and fall down. Same thing with drugs. They can make you just have a stupor. Not stupid, but have like a walking stupor, just not walking normally. Most of the time though, a lot of hospitals, if they come into a hospital, they're complaining of dizziness, a lot of times they just don't figure out why. Just a weird thing that happens. Big thing, just rapidly identify any kind of life threats. Getting all the important information you need, asking good questions, getting all the information you need on scene, because you can't get halfway down the road, turn around and go back and ask a question that would have been important. So try to get as much information as you can within a time constraint before you get this patient on the road to the hospital.